So, friends, yes, good evening. Thank you so much for joining. I think we should get started without further delay. Before,
We can't hear.
yeah, so before I introduce the guests, I think, Vandana, I need to introduce Vandana. She's a Ramdas Pai PhD fellow in our lab at Manipal University, Jaipur. So, a gold medalist and a graduate in biotechnology from Amrita University. She went on to work for NRS in the university, and she has a prolific track record with her MSc in bioinformatics, from Amrita University. So thank you so much, Vandana. So Vandana is going to moderate the session today. I'll quickly introduce the guests today. We have Simon S. Khan, who is a hospital geneticist and a senior scientist based in Australia. She has over 2 decades of experience, not only working as a geneticist but also as a genetic counselor. We have Soham Banerjee, who works for Sharanya Research Hospital, and he is also a well-known genetic counselor, a BGCI, certified genetic counselor. And we also have two others who are coming up. I think I don't see them. One is Kaushal Nayaz, who is the founder of Arbit Bioservices, and Sunil Kodipalli, who is also a genetic counselor and cytogeneticist. And incidentally, and of course me, who will also be part of this small panel, where all five of us, all six of us belong to GCCI, Genesis Clinicians Consortium of India, which is a spin-off of a consortium between Bioclues and Bioservices. So the subject of panel discussion today is rare diseases largely associated with mitochondrial genetics. And this is because we are celebrating the mitochondrial disease week as well, apart from prostate cancer week. So Vandana will take up the proceedings from now. Yeah. Over to you, Vandana. Kausal has just one whom I just introduced. Yeah. Over to you, Vandana, please. Huh? Thank you.
Thank you, Prash. Hi, everyone. I'm Vandana. So, I guess we can move on to the questions without wasting any time. So, to begin with, Dr. Saima, could you briefly explain what mitochondrial diseases are and how they fit into the larger category of rare diseases?
Thank you, Vandana. So, if I'll talk about mitochondrial rare genetics, then these are disorders and diseases that are a diverse group of conditions which are basically caused by dysfunction of mitochondria, that is the energy producing organelles in the cells. So, since mitochondria are essential for energy metabolism, their dysfunction can affect multiple organs, particularly those which have high energy demands like brain, muscles, heart, kidneys, and liver. So, if we talk about the mitochondrial genome, we all know that mitochondria are basically inherited from the mother. So, whatever mitochondrial mutations or the genes we will be talking about, they are all maternally inherited and have their own DNA. That particular mitochondrial genome, nuclear genes, the nuclear genome the cell is actually having. So many disorders are heterogeneous in nature. If we talk about mitochondrial disorders, specifically like MELAS, mitochondrial encephalomyopathy, lactic acidosis, and stroke like episodes, all these things, and there are specific genes, very specific mutations associated with these disorders. Even if we talk about MRF, that is myoclonic epilepsy with ragged red fibers, that is also one of the rare mitochondrial genetic disorder, and it is also very specific to a very specific gene, mttk mutations that happens, and then Leber's hereditary optic neuropathy, which is very well known and well studied, and the genes responsible are nd1, ND6 mutations in the mitochondrial your DNA. So this is something very unique in a way that you have a separate genome which is actually harboring its its own gene and have relevant mutations happening inside, causing a separate set of diseases which are originally and maternally inherited.
Yeah. Before I'm sorry, Vandana, to interrupt you. We also, I forgot to introduce Ashna. I'm really sorry, I apologize. Ashna Narayanan is also BGCI certified genetic counselor based in Hyderabad. I'm really sorry for that. Yeah, go ahead, Vandana.
Thank you, ma'am, for the detailed explanation of the mitochondrial disease. So, now moving to the next question, I would like to ask Dr. Kausar, like most rare genetic diseases are known to be as monogenic. So, how does this apply to mitochondrial rare diseases? Dr. Kausa, are you there?
Yeah, Kausar, are you there? Kausar Nayas, you're muted. Yeah. Or maybe Soham can take that in the meantime. Yeah.
Yeah. Hi, sir. Hi, Vandana. So specifically, it's can be defined why they are monogenic. Is tend to be monogenic because, especially in the rural and periphery, what we have seen is when a patient came with a category of broader things like whole exome or whole genome, this kind of sequencing or this kind of molecular assessment. That time we find a single gene disorder is associated with this condition. So this tend to be monogenic. And monogenic have a diverse effect in the completion of the symptoms and the criteria. So it's tend to be monogenic in that way. And I think Kaushal sir would be a better person to describe this in a broader way. But I just tried.
Thank you, Soham. So, like, so next I would like if anyone in the panel or in the meeting would like to ask anything or like to add on any points, it's open.
Yeah. So if I can just add, Vandana, so as Saima and Soham, made it a point. One of the major challenges with understanding the disease manifestation with mitochondrial diseases is the MELAs, which are mitochondrial encephalopathies and that are associated with lactic acidosis and stroke-like episodes, which we call it as MELAs. And of course, there are other syndromes, syndromes like neuropathies and the Lyme syndrome and other things. But many a time, since they are monogenic, there could be nuclear encoded, genes that are associated with mitochondrial, disease manifestation as well. Or there could be mitochondrial encoded nuclear, genes as well, the other way around as well, largely affecting, many of these particular diseases, which unfortunately, we cannot probably, be able to, identify. So since, the disease manifestation is a kind of a major challenge, and because they affect, these particular organs, that leads to various symptomatic conditions, we have to ensure that the maternal inheritance, matters a lot. So that is probably one of the reasons why we may have to go for a clinical exome or whole exome sequencing, like what Soham, points out. Yeah. Maybe Ashna has a point. Yeah. Thank you.
Yeah, good evening, everyone. So I wanted to add one more point, which is very much, relevant to mitochondrial inheritance, you can say, the phenomenon of heteroplasmy, which is basically presence of different coexisting types of mitochondrial DNA within a single cell or a tissue. So, as mentioned by Dr. Saima, Dr. Prash, and Soham, that mitochondrial inheritance is the process by which, mitochondrial DNA is usually passed from mother to offspring exclusively. So this the level of mutation in the mitochondrial DNA in heteroplasmic individual influences the disease severity. So even if a person is carrying a mitochondrial mutation, the severity depends in how many cells of mitochondria does that mutation actually persist. Because what happens this during the random segregation happens of mitochondrial DNA in the mother's oocyte during gametogenesis, which can lead to significant shifts in these levels from mother to child. So a mother can carry less number of mutant DNA in mitochondrial genes as compared to the child or the offspring, basically. So there's another reason. This is main phenomenon through which you can see there is a variation in the disease presentation among individuals, even if they have inherited the same mutation from the same mother, basically. So this is also one of the major phenomenon which happens in the mitochondrial inheritance pattern.
Yeah, thank you, ma'am. So the to add on with what Presh said, this is a comment and this question is open and anyone with their opinion can answer to this. So it is like there is a continuous bidirectional communication between mitochondria and the nucleus. So how do the mitochondrial encoded genes influence the nuclear function and vice versa? Like how do the nuclear encoded genes in turn regulate the mitochondrial activities? So if anyone would like to comment on this, it's open.
So this I can quickly comment if others are waiting to comment on this, because this was a part of my PhD way back in 2004 when I started. So we were looking into something called some of the hypothetical proteins that are targeted to mitochondria, largely associated with some colorectal cancers. There's a very well-known syndrome called Lynch syndrome, which affects the colon and rectum of humans. And this guy, there is something called MLH1, which is methyl 1, which is a DNA mismatch repair protein. So this particular protein, apparently piggybacks between mitochondria and nucleus. It was believed at some point of time it was localized in nucleus, but later on, it has, flourishingly came to existence that this particular protein piggybacks between these two organelles, mitochondria and nucleus. And there are some rare missense mutations associated with this, condition, which affects not just colon or rectum, but also other tissues as well, other physical tissues like eyes and other things. That is where these neuropathies like LON, LH1, and the MELAS, which I was telling you, and also the Lyme syndrome. All these particular, things, occur because of asphyxiation, that takes place within mitochondria. So because mitochondria is such a small genome, which is about 16,800 and odd bases. So even if there are 6 mutations that are happening, because of those inherent mutations, not just several organs or tissues keep on getting failed, but as a result, mitochondria gets asphyxiated and the cell gets asphyxiated and the cell eventually dies, affecting the other organs and tissues. So that is the reason why some of the proteins are forcibly asked to get out of that particular mitochondria, and they pervasively sit outside mitochondria and still affect that particular tissue. So this is how the mitochondrial encoded nuclear diseases happen, or mitochondrial or the other way around, even the nuclear encoded mitochondrial, diseases also happen. As a result, mitochondrial DNA instability happens, and as a result, the mitochondrial DNA gets deleted and depleted, and as a result, there is a decreased number of mitochondrial DNA molecules that happen within the cell. That is how this particular manifestation happens. Yeah. Thank you.
Thank you, Prash. Would anyone like to add any points to Prash? Okay, if anyone have any more questions on the topics that we have discussed or anything, it's open.
Yeah, I would like to just mention, along with what Prashant has discussed, that the nuclear genes have a great role in they assist in the replication and maintenance of mitochondrial DNA. That is a very crucial help that comes from nuclear genes, as they provide the enzymes and proteins required for copying and maintaining the mitochondrial DNA. For example, Pol-G, that's your mitochondrial DNA polymerase gamma, and uh, for some of the enzymes I am not able to recollect right now, but Pol-G I remember. And apart from not only this maintenance of replication and everything, even transcription and RNA processing, that is being supported by many of the nuclear factors, nuclear genes, which actually help and assist mitochondrial DNA. So entire process, rather I should say. So it is more like hand in hand help by the nuclear genes, because mitochondrial genome, as Prashant said, is very teeny toony of 37 genes. So that is a good help, I can say, and and that also influences to some extent the expression of mitochondrial genes.
Yeah, thank you, ma'am. Um, Ma'am, like what do you think are the most common clinical manifestations that would raise the suspicions to the mitochondrial disorders? Dr. Saima?
Yeah, sorry, Vandana, I'm sorry. Can you just repeat the question for me? What did you
Yes.
say?
Yeah. Ma'am, what do you think are some of the most common clinical manifestations that should raise suspicion of this mitochondrial disorders?
Yeah, okay. So, uh, sometimes there are specific clinical manifestations, I should say, which are associated with specific type of disorders. If we talk about like melas, there are specific neurological manifestation that will incline what I can say clinical manifestations over the phenotype of the patient. Like there will be specifically there will be seizures, and then stroke like episodes. There will be ataxia and developmental delay, and there will be peripheral neuropathy uh, that are associated with specific genes. So like that, and specifically, and if there is any other family history, if any other disorder that is being ever picked up in the family, like suppose the mother is being affected with anything, or any other sibling is being affected with something, and you have a family history along with the clinical manifestations. So these are specific, like if I'll talk about Leber's hereditary optic neuropathy. So there is a pigmentary retinopathy, and there is a progressive what is that specific term we we use it as a clinical manifestation. There's a vision loss, central vision loss, and there's a progressive external ophthalmologias where you have a degeneration happening, which is specific to the ocular manifestations which inclined toward this disease. So, clinical manifestations in terms of presentation, and definitely the family history, if anyone is being reported in the family to have specific disorder. Apart from that, there is no specific inclination, because the limited you have limited disorders associated with mitochondrial diseases, and they have a specific, being monogenic in nature, a very specific classic phenotypic presentation.
Yeah, thank you, ma'am. Soham, you
Yeah.
can.
Uh, Thank you. I'll just like to add few things with Saima ma'am's points. Just like ma'am said, the manifestations and the clinical features, they are really very common. And we know mitochondria is our cellular powerhouse. So if any kind of mutations or any kind of problem happen to mitochondria or mitochondrion, the main thing what we can expect is a weakness, fatigue, blackouts, this kind of common clinical features. And the main part of this mitochondrial disorder is to have a proper diagnosis. Very often, we fail to diagnose whether it's a mitochondrial thing or any other thing. Similarly, if we can see about a good family history, just like Ashna told few minutes ago, okay, maybe the manifestation is not same. Mother, the carrier might have less manifestations, the affected children have more manifestations. So these are the few points what you need to take care of, whether we're collecting a and seeing for any mitochondrial conditions. Over to you, Ashna.
Yeah, so continuing to what Soham just described, broadly, either mitochondrial disorders can manifest in the childhood or in the adulthood. So, because it is of maternal inheritance, you can find the symptoms of maternal deafness, deafness running in the family, and sometimes even diabetes. So, you can see in a family pattern, only females will be affected. So in that case, also mitochondrial, mutation suspicion arises. But in pediatric setting, basically in neonatals, as Soha mentioned, fatigue is one of the commonest form of clinical manifestation, which can be presented as lethargy, and many doctors will say that there is a failure to thrive, which can be associated with any kind of lactic acidosis, along with multi systems are involved, as Dr. Saima mentioned in the starting. It could be related to seizures, stroke, cardiomyopathy, blindness, or movement disorders. So to have a proper diagnosis of mitochondrial, uh, I mean, these are some of the common symptoms which can be also included in any nuclear genes which are affected. So a doctor has to look into certain biochemical parameters, or maybe, uh, specific tissues, or maybe specific system which is involved. And firstly, usually they rule out nuclear genome, but ideally in case of pediatric situation, it is very much effective to rule out both nuclear and mitochondrial mutations simultaneously in neonatals.
Yeah, I mean, just added to that, maybe because it's a mitochondrial maternal inheritance, how maybe Vandana may want to ask Soham and Ashna, or maybe Saima as well, on how you as genetic counselors would probably, take up the role to counsel them not only, towards genetics, but also, from a psychological standpoint of view.
Prashant, definitely for psychological and genetic counseling part, Ashna and Soham will be the appropriate candidates. But yeah, when we know that the inheritance is maternal, then that is an inheritance principle for mitochondrial DNA mutations. So we have to focus around the pedigree, definitely, that how many females are being affected, because the both the sons and daughters can be affected, but however we know that affected fathers do not transmit the disease to their children. So the trail of that family history which I was talking about, apart from the classic phenotype that is being associated, if we are focusing towards mitochondrial disease only, because usually for failure to thrive or lethargicity, which comes under failure to thrive, or usually they are also being analyzed for neurological manifestation if there is any other possible co-manifestation is existing in the phenotype of the patient. So over to you, Ashna and Soham, for detailed counseling part.
Thank you, Saima ma'am. It's not about only mitochondrial. If any kind of disorder, any kind of disease, the psychological part comes and makes a large perspectives of any kind of genetic counseling, especially if it's mitochondrial. And as we know, the inheritance pattern is from mother to the son or the daughter. So this kind of thing comes if we are practicing in urban or rural, both areas. It's completely depend on that particular couple mental makeup, whether they are preferring what they want to do. Because sometimes what happens, sir, this kind of cases can turn into some mutual divorces, mutual separations, and these things also come up. So we need to take care very carefully. And sometimes it's not only about the counseling to the couple, it's counseling to the entire family and separately. So these things we need to take care of. And very honestly to say, after such counselings, we also need some psychological supports from our own therapists. So we'll recover soon. Over to you, Ashna.
Yeah, I mean, I agree with Soham. One of the main things in like in every counseling session which we face, specifically if it is X-linked or only mother related, is first of all the mother's guilt. So whenever we break out the news that okay, this is of this sort of inheritance and you are the one who has passed down the mutation, or the possibility of this mutation being passed down to the offspring is majorly mother. First of all, the guilt, the shame they face is very much prominent. Like every mother, they don't want their child to be affected. So, like Soha mentioned, how couple counseling is necessary. I particularly make sure that the person in question, if it is X-linked or maternal inheritance kind of situation, that person should be given extra care regarding the psychological support. I mean, pertaining to the psychological support, that person should be taken into consideration, that okay, they should be assisted properly. Secondly, a couple counseling should be happening. Then the husband should be counseled properly, again separately from the mother, that what are his point of view. Then definitely family counseling or group counseling is one of the way in which you can make the family understand that there is no one, it's nobody's fault that okay, this mutation is there in the family. Because in mitochondrial disorders, like I mentioned earlier also, there are so subtle symptoms which happens in the adulthood. Sometimes majority of the females or majority of the family members do not know actually that okay, this is the prominent symptom. For example, diabetes. Okay, diabetes is so common, it is polygenic, it is multifactorial. Now who would expect that okay, if in a family only females are getting affected, they will not actually think as a family member that oh, something must be running in the family from maternal side. It's just like they will blame the habits, the lifestyle, or maybe the obesity. In healthcare, anything related, anything happening to women falls down on their weight, on their lifestyle, and many things. So it doesn't strike to them that okay, if I'm having this deafness, I'm having this diabetes which is running in the family, it will not get strike to them. So when actual diagnosis happen, it not only affects the one member but also the previous mother. Generational trauma kind of thing happens, that, oh, I have passed it on to my child, and she has passed it on to her child, and the child will pass on to the next generation. So I think individual counseling, couple counseling, group counseling, and to deal with uh, the guilt and shame of a mother is the topmost priority in any kind of disorder, which either exclusively falls into paternal kind of inheritance or maternal kind of inheritance. Now, because we are talking about mitochondrial, it's maternal inheritance.
Yeah,
Yeah, that is my point.
yeah. Just added to this point, I mean, I still remember during my childhood, there is a typical tribe in the state of Telangana called Lambadis, which I also discussed in Omics group. In fact, there are many sicklers actually, and of course, with hemoglobinopathies as well. And although many of these sickle cell or hemoglobinopathies are nuclear encoded, but large amount of mitochondrial dysfunction was labeled, for the root cause of such kind of even sickle cell diseases or hemoglobinopathies as well. And that was because the very poor in nutrition, no good energy, very pale, very thin, very dark suited skin, and all those kind of things. That's a very pitiable situation. So that shows that how mitochondrial diseases are largely manifested even for other monogenic diseases like sickle cells or sickle cell or other hemoglobinopathies as well. Yeah. So that was my another quick point. So maybe Kausar is here if they can comment, or maybe someone like Akshay, if you have any quick comments, or someone else. Maybe Vandana can wrap it up. Yeah, please.
Yeah, Prashant, thank you so much. I think I was not initially here actually, though I was logged in actually because of some other calls. So I missed the initial part actually. But what I can say, though it's not my niche area, either like, research or counseling sessions, but today I opt to be a student rather than, mentor today. So I really enjoy through all the sessions actually. But I wanted to know one thing, Prashant. You remember when we met last time in the Jaipur, you were discussing about one interesting case, that colon pouch. So
Yeah.
you did some.
Yeah.
So
Pouch, yeah, pouch
yeah, I
pollen
mean,
is not mitochondrial. Pouch pollen is not at all mitochondrial. Yes, but there could be
okay,
mitochondrial dysfunction. Actually, there could be,
okay,
which
okay,
we are
okay.
still working on
So
it. In fact, that is Vandana's
yeah,
PhD.
I
Yeah, yeah.
okay. So I was little confused because I didn't go into the detailed discussion. So I just wanted to know, because all of you are into it and doing good research in this area. So can you take, like, where we are right now, and what is the clinical outcome for that research? And I mean, just it's on behalf of curiosity. I just asking with all of you. Yeah.
Yeah. So
How we have
pouch
managed?
pollen is
Yeah,
very,
yeah.
yeah, pouch pollen is very native to I would say Pali and Jodhpur region of Rajasthan. Although there are one or two cases that were reported from Indian origin or Pakistani origin people in Doha and also in Denmark. In fact, one case. Yes, there are some rare variants because the anorectal malformation is largely associated with pouch here, where the child is born with a dilapidated, intestinal pouch that is carving out from his, genitourinary area. So the child needs to be operated very quickly, and our surgeon, Dr. Praveen Mathur, he has done almost 800 surgeries so far, actually, for these rare diseases over the last 35 years of his career. But yes, although it is a rare disease, it is nothing to do with mitochondrial. We have done some
Yeah.
good amount of trios and quad based analysis. But one of the major things that I just made it a point was, yes, there could be a reason due to that there could be mitochondrial
Mm,
dysfunction happening
mm.
in these particular patients, and as a result, mitochondrial dysfunction is probably leading to you know leading to the pouch
Okay.
derangement,
Okay.
right
Okay.
from right from the parental genotypes or whatever. So that could be the reason. But yes, we are still finding out the reasons. Yeah, yeah. Thank you, Kostya.
Yeah, to add
Yeah.
on with what Mrs. Soham and Ashna ma'am have mentioned, I have a question. Like, um, you have mentioned how or to what extent the families are collaborating or are agreeing with the diseases or when they find out these defects. So, are these also play a role in why this mitochondrial diseases are often undiagnosed or misdiagnosed, particularly in countries like India?
Yeah,
Um,
maybe Akash can take it up, but
yes.
I have one quick comment. That could be because of lack of awareness. That is number one. So the first onset, right from the onset till the till the patient comes to the doctor. Even the doctors also, they keep it unknown, because because of their immaturity or not knowing all those kind of tests. But things have started improving. But as probably Ashna or Soham, made it a point, okay, that there's a large amount of, inherent stigma, because they don't even come and attend the doctor and say that, okay, this is the reason, or this is the reason why, this disease is happening, and all this kind of things. So until, the patients, come to the doctors, they come out of those particular so-called pitiable comfort zone and attend the doctor, and the doctor is also very potent and recognizes the importance of that particular disease, then we can probably come out of that particular diagnosable situation. Yeah, thank you.
Yeah, that's true, Prashant. And as Ashna said, that clinical heterogeneity, you know, the mitochondrial diseases can affect any organ. So it gives you most of the time, in the first instance, a very overlapping kind of a symptom where you can't differentiate specifically it is mitochondrial, it is nuclear, why this is happening, and then symptoms may also vary widely among patients. So early signs
Okay, okay,
may be just non-specific
okay.
to in many
Yeah, yeah,
cases.
okay.
So these are the reason
Thank you.
clinicians may misattribute symptoms to some other common disorders, and that's the reason that early diagnosis sometimes are not able to be made at the right time. But it is, I believe, with my personal experience at good hospital setups where they have proper genetic departments and everything, things are not that as bad as they were in, like, maybe couple of decades like back.
Yeah, adding on to that, I would like to comment about the fact that women in general do not actually, you know, allow themselves to have a proper access of healthcare, even if they face any kind of symptoms, specifically in rural areas, specifically in a tribal population or maybe backward population, where maybe they think that okay, it is something which I or my sisters or my mother had been born with and it will be running in the family, and they never go to the doctor. And even there is a lack of awareness among the clinicians. It depends where they are going. So because there is a subtlety of symptoms across this maternal and mitochondrial inheritance. Sometimes they'll be presented with only one system symptom, sometimes multiple. So they actually tend to avoid, and even if they give birth to the to any child, because they are going to that particular healthcare system only, where they are not aware that okay, it could be running in the family. So by the time, due to maybe economic unfeasibility, they miss out the diagnosis, and by the time, but by that time, actually, the child is no more to take care, or maybe no more symptoms are there, or no more samples are there, basically, to provide that kind of healthcare facilities to those families. So this is also one of the major point which happens in India. They do not know where to go. They do not know what is happening to them, and there is a there is a whole social construct where women tend to ignore their own symptoms, be it little headache also. So, and which is very much prominent in rural areas, let alone urban areas. So that is one of the major criteria through which mitochondrial diseases are missed out in rural and urban population in India. Not only lack of awareness amongst clinicians, but lack of awareness amongst women and family in general. That okay, they have to go to the doctor.
I
Yeah,
agree with you,
gender bias
Ashna.
is one of the factors. Truly, I agree with that. That sometimes, uh, even if the child is being born, and if it is a, I have personal experience in some other disease, where the child, if it is male and there are complaints, they were brought to the clinic to address the manifestations at a very early age as compared to the females. So that also. Like one of the reasons sometimes that you are not able to catch it at the right time.
Thank
Yeah, I
you.
think very well said. I think it's time we wrapped up. So maybe Vandana, if you would like to quickly summarize so that we can have a quick meeting, among us GCCA members, please. Thank you so much.
Yeah. So thank you all for joining the meeting. I would like to thank the panelists for their valuable insights and to the audience also for joining us. So today's discussion highlighted the complexity of these mitochondrial diseases and the importance of accurate diagnosis and the need for especially the collaboration between the research, clinical care, public health. So, yeah, with that, I would like to conclude the session, and once again, I thank everyone for joining. Thank you.
Maybe we can have a quick photograph, please, if everyone switches on their camera, please. Thank you so much. Yeah. And thank you, Vandana, for this, wonderful moderation. Huh? Yeah. So can someone take a good photograph, please? Yeah.
Yes, Prasha, I have taken.
You're taking it, is it? Okay, good. Then I'll start. Yeah.
Yeah, thank you all.
Thank you, Vandana, and thank you, everyone. So, friends, let's give a big thumping round of applause to Saima, Soham, Ashna, and of course, Kausar. Thank you so much, and of course to Vandana as well. Thank you so much, Vandana, for asking terrific questions. So, long ale mitochondrial awareness. So, this sums up, mitochondrial awareness week, which we usually, keep on organizing this mitochondrial awareness or rare disease this thing. But there is also a certain difference between mitochondrial diseases, rare genetic diseases, and genetic diseases. So, as a pupil, if we can understand that, that will be nice. Okay, yeah. Thank you so much. So, all GCCA